A very good morning to everyone. First of all, I would like to thank Jay Gayatri Madam and Daikar sir for inviting me this year. Last year also I happened to come here. I learned a lot from Narvinde Hospital. Actually, truly I have to admit from that. Because without this, I don't know I could have seen this much of cases in my lifetime. Okay. So today's topic is CT and MR imaging of orbital infections and inflammations. So my previous speakers have already demonstrated how we'll differentiate. So to summarize, we'll just see how we're going to differentiate this orbital inflammatory diseases. So in the inflammation, if it involves a lacrimal gland, it's dacroadenitis, right? So in imaging, we'll be seeing the lacrimal gland enlargement. If extraocular muscles are involved, that is myositis. And in myositis, as Usha madam has said that, so it will be with the acute presentation. It can be unilateral with acute onset. It can also involve bilateral also. So muscle involvement, we cannot say that. So if multiple muscles involved or a single muscle also involved. And madam has asked that why it was called as idiopathic as a pseudotumor, because sometimes this idiopathic orbital inflammation, they will be presenting like a mass-like picture. Okay, so immediately we should not jump to a diagnosis that we are dealing with a mass lesion. Sometimes, as madam has said, that the myotendinous junction will be involved. If the myotendinous junction is involved, we are dealing with myositis. And as she said that if any cause is not found, then we come to idiopathic. In same scenario, instead of the smooth involvement, if a mass-like presentation will be seen, at that junction, pseudotumor means it is also called as a false tumor. So that is why the name came as pseudotumor, and it is not neoplastic. It is just the inflammatory thing that is seen. So the immediate immediate radiological differential diagnosis for the closest of the orbital pseudotumor is the orbital lymphoma. And how do we differentiate between idiopathic orbital pseudotumor and a lymphoma is, once again, as madam said, we have to treat it. That is the only thing. Radiologically, we cannot say this is lymphoma, this is orbital pseudotumor. Sometimes lymphoma, they may be present with both sides, they also can be presented. Okay. Or unilateral also they can be presented. With the clinical history, with acute onset presentations and not responding to steroids, that history is very important for us. That is why we discuss with the patients. Just seeing only on the imaging, we cannot come to a diagnosis on that. So that is why we say that since it's not responding to steroid, then we give the closer differentials as a orbital lymphoma, and HPE it has to be proven that we have to admit to that. Okay. Next one is with optic nerve sheath. Okay, so only if the sheath is involved, it is called perineuritis. Suppose if it goes deeper inside and the nerve is also involved, then it is neuritis. So in imaging, we see the peripheral enhancement about the optic nerve with varying infiltrations of surrounding fat. So that is the one beauty to discuss about this neuritis, because surrounding the nerve, we'll be seeing that fat stranding. As madam was saying that suppose in neuritis case, if it is a larger lesion, we bring the diagnosis differentials of lymphoma and glioma into the scenario. But the hallmark to find this neuritis is it's an inflammation. So surrounding the nerve, there will be fat stranding and inflammatory changes. Whereas in meningioma, we don't find these inflammatory changes. And the tram track sign, the orbital nerve will be preserved in meningioma. In the contrast study of CT or MRI, you can very well see that optic nerve, but in meningioma. But in glioma, you cannot see. Once again, glioma will be seen more in pediatric age group. Then you have to go into the neurofibromatosis and all those things, you have to work it out. Okay. So perineuritis, it is only the inflammation surrounding the sheath, or neuritis, if it goes deeper, the optic nerve thickening and all those things will be seen here. And or orbital periorbital cellulitis. That is again a bigger topic that we'll be discussing in future slides. Orbital apex, when it is going deep into that, okay, that's called as the Tolosa-Hunt syndrome. Next, periscleral, that is periscleritis. Okay, the first one is, we'll start from lacrimal gland. So as madam said that lacrimal gland infection or inflammation need not always be associated with any organism. Idiopathic also can come. But in imaging wise, what we see is, this is an axial section. That is, our orbit is cut into like a carrot, like slices. Okay. So this is coronal section, like you're seeing from me, no, anterior to posterior. And this is the sagittal section. So this is the beauty of this CT scan. Even in tier 2, tier 3 cities, nowadays CT scan is available. 24 hours it is available. Just in a jinx, you can see all these structures in all three planes. So that is the beauty of this. And this is the left lacrimal gland. And another beauty in this imaging is you can always compare with right and left. Okay, that we should always compare. Okay, that's why we know how enlargement is this the right lacrimal gland, and because of the inflammation seen in that lacrimal gland, the dacrodinitis, and it is also causing the preseptal edema. Okay, one air pocket is also noted here, but on the left side, the lacrimal gland is normal. There is no inflammation in the preseptal area in left orbit. So this is normal. Okay. So this is the right one. Once again, in the coronal section, we are seeing the lacrimal dacrodinitis inflammation. This is the sagittal sequence. So this is our case. This is in the left side we are seeing. Last time it was right side. No, it is in the left side. The left lacrimal gland, there is infection, inflammation. So if it is treated, then mostly it will get settled. Suppose if with immunocompromised patients, if it untreated, then definitely it goes into the preseptal edema, and the preseptal inflammation changes also will be seen. These three are axial sequences. This is the coronal sequence. So this is soft tissue window. We should know to which window we have to see. Okay, so soft tissue window only we can see the orbit. We should not see the orbit in the brain, in the bone window. In the bone window, only the sinus, any sinusitis, any bone erosions. So all those things we have to see in bone window, which will be telling you in the next slides. Okay? So this is that myositis. When the inflammation is seen only confined within the muscle. So here the myotendinous junction is involved. So this is a smooth involvement, okay? Unilateral, the lateral rectus muscle right side is involved. And can you see the internal, this fat standing is now itself, it is started, okay? But here it is not that much. It is also associated with the preseptal edema and the preseptal inflammatory changes. So this is, once again, as Madam has said, that this idiopathic term should be used only when HPE is proven. But imaging wise, when we find these kind of mass-like presentations with acute onset, and we give one of the closest differentials as a orbital pseudotumor. This is why we use the term called pseudotumor, because here suddenly it looks like something like a huge mass is present. So this is involving the inferior aspect here. The inferior rectus muscle is pushed also here towards this thing. But to see the rest of the muscles and all looks fine. Okay, there is no increased thickness or anything. But here the clue is there that there is a surrounding inflammation in the preseptal area and this thing. So we give the closest differential as a myositis. So this is MR imaging. So pertaining to optic nerves, MRI contrast gives a better resolution. CT also is that is sufficient, agreed. But MRI will give much more very good resolution. See here. So this is the central nerve portion. And the peripheral, when the contrast is being given, the peripheral enhancement is noted. Usually nerves will be very thin. Okay, they'll be very smooth. But here, there's because of inflammation, patchy enhancement is seen here in the periphery also. And surrounding this nerve in the coronal section, there is perineuritic inflammation changes noted. It is dirty, right? This is the clear fat. So this sequence is called fat suppression sequence. In MRI, the sequence to look for orbit is we need the fat sat sequence or the stir sequences. The routine sequences like T1, T2, all those things you might have heard, no? They are all for brains. For orbit also we can do for just for anatomical visualization. But when we are dealing with inflammation, this is the sequence we have to look for, because here is the right optic nerve. There is not much of inflammation. But here you see how the optic nerve thickness is increased, there is heterogeneous enhancement, plus also surrounding inflammation changes are noted. See how the optic nerve internal signal changes are noted here. So these are all the advantages of MRI with better spatial resolution, and contrast will play much more role in the enhancement pattern. So optic neuritis, to summarize, it's unilateral optic nerve swelling with high signal and increased thickness. Non-infectious is more common, and mostly they'll be associated with the demyelination. So multiple sclerosis, NMOSD, and also the MOGAD, antibody associated disease. Multiple sclerosis, mostly they are unilateral and they are short segment. But whereas NMOSD and MOG antibody associated disease, they are bilateral. The involvement of the optic nerves, the thickness and the length will be larger than when compared to the multiple sclerosis. And always we have to screen the brain, When dealing with demyelination, protocol is suspected of demyelination, we'll be screening the brain and as well as the whole spine. One sagittal cut of a spinal cord is necessary. Okay, because all these things, the spinal cord will be involved. Okay. And MRI is the modality of choice with contrast study. As I said, these are the sequences to be looked for orbital inflammation apart from the routine sequences. And the MRI imaging we have to do in thin sections. Okay, not the routine sections like 5 mm, 10 mm. So optic nerve is a very hair-like structure. No, superior ophthalmic vein, these optic nerves, all those things are hair-like structure. We have to take the sections in like 1 mm or 0.5 mm. So that is where even the mildest of inflammation changes can be seen. And the beauty is we get images in axial, coronal, and sagittal. Nothing to do for that. Okay, in 3D MPR, we can see in all planes. So this is a case of optic neuritis. This is CT scan, right? So the right one is normal. So you look at the thickness of right optic nerve. That is the normal thickness. But what's happening in the left side is it is very well thickened. The enhancement, this is a contrast study. The enhancement, it is showing heterogeneous enhancement. Look at the surrounding orbital fat. It is very clear, right? But if you see here it is dirty. So this is why we are stressing upon to do that fat suppression sequences. So we can see the orbital fat infiltrations or the haziness that is noted. So it's a case of optic neuritis. This is CT. So you see the difference between CT and MR, how the spatial resolution is there. Okay. Now, the closest to the differential, suppose if it is presenting like a mass-like pattern, we bring optic nerve meningioma. Straight away inflammation, we give it as optic neuritis. Suppose if it is a larger, as Madam showed on the slide, no, one of the optic neuritis, it was looking like a glioma for me from there. But this is a classic example of optic nerve meningioma. This is called tram track sign. What is tram track sign? So this looks like a train, no, this optic nerve. These, the mass, this is the heterogeneous enhancement. So that is like a track. So the train is going through that, okay? So this is called tram track sign. The optic nerve is preserved. It is arising from the sheath and it is encircling it. So when this picture is seen, then we can, we'll give a closer DDS, optic nerve meningioma, rather than optic neuritis. Then see how the mass is there, but there is, the fat looks very clear. There is no inflammation changes in the fat or in the eyeball or anything. Okay. So this is how we have to differentiate between optic nerve meningioma and optic neuritis in imaging aspect. So this is another DD of optic glioma. So here see the optic nerve is actually displaced and also it is even involved. Actually, it's not very clear. But here, see in the CT scan, the same case in the CT scan, the optic nerve is completely involved. The tram track sign is not noted here. Tram track sign will be seen in contrast study in both CT and as well as MRI. Okay, now if the inflammation is going much more deeper, okay, we'll see what it is. That's called Tolosa-Hunt syndrome. So what is Tolosa-Hunt syndrome? Inflammatory changes when they are seen in the cavernous sinus area or in the superior orbital fissure or in the orbital apex. Okay, so what do we see in a CT is asymmetrical enlargement in the region of the cavernous sinus. If you give contrast study, this is the internal carotid artery. The pointer which I am showing is the internal carotid artery in the right side. In the left side, the internal carotid artery is effaced or the diameter will be in a smaller in size. So without any history, if we see that the internal carotid artery diameter is reduced because of enhancement in the cavernous sinus, then we'll open our eyes and see, okay, we are nearing towards Tolosa-Hunt syndrome. So then we used to see the other clinical this thing, and we have to see whether any systemic causes are there or not. And as usual, we have to prove it off then. Because this, if it is because of inflammation, this will respond to steroids. And in follow-up imaging, this will reduce. Once if it reduces, we'll get the same pattern in the right side, no? How the enhancement is very smooth. The same pattern will have enhancement. The internal carotid artery actually widens up. So contrast study is definitely required. Particularly MRI brain contrast is the modality of choice when suspected with Tolosa-Hunt syndrome. The resolution of enhancement following treatment will be seen here. If Tolosa-Hunt syndrome, then the cranial nerve palsies, the 3, 4, and 6 will be, they'll be presenting. So if the inflammation is surrounding into the sclera. It's called as a posterior scleritis. So here, this case, there is the walls are enhancement is increased. It is thickened. Plus also there is a periscleral edema is noted in the retrobulbar area. There is also preseptal soft tissue swelling with edema. So this is a case of a posterior scleritis, and this case is a case of a lupus presented with acute onset bilateral orbital pain. So finishing inflammation will go into orbital infections. So how do we classify it radiologically with infection is, so this is the septum, this black line, okay? So whether it is preseptum or whether it is postseptum, or whether the lamina papriciae is eroded and is it causing any abscess-like presentation, or this entire thing has converted into a orbital abscess. Okay, inflammation, infection, clinically you can diagnose. Okay, what is the role of imaging is, what is the depth of involvement it has happened. So that is where this CT scan actually helps. Suppose if it goes deeper into it because of the orbital cellulitis, immunocompromised, or patients who are not getting proper treatment, what happens is that it directly causes this cavernous sinus thrombosis. So these are the type 1, 2, 3, 4, 5, depend on the anatomic extent. So what is the role? As I said, the anatomic extent of the disease. So where does it got spread? Preseptal, postseptal, cavernous sinus, and intracranial involvement. And the beauty about doing the CT orbit is the sinus will also get covered automatically because it is very close to there. So we have to see from where the infection is coming, whether is it from the dental or from the sinus, or is it from the brain, or this orbital cellulitis will also cause cerebral abscess and cerebritis. So from where this infection is caused, CT is the imaging investigation of choice initially in the first line, readily available, and will identify the subperiosteal reaction or intracranial extension also. So periorbital cellulitis, as I said, so the definition of the planes, whether it is involving the intraconal fat, whether it is intraconal or extraconal soft tissue mass, edema of extraconal muscles with abscess, with endophthalmitis, how it is presenting, we can see in periorbital cellulitis. So this is type 1 of preseptal cellulitis. This case has bilateral preseptal cellulitis. Okay, so this is the septum, and there is no inflammation changes in the muscle or in the orbital area. This is a coronal plane, right? So coronal plane, see what is the advantages. The surrounding soft tissue is also seen in the frontal, and minimal inflammation changes are extending into the zygomatic and as well as the temporal soft tissue areas also in both sides. So that is where we have to see in the extras, apart from the orbit, we have to see outside also what is happening in the sinus, and that we should see in the bone window. This is a soft tissue window where we have to focus on orbits. So this is a case of a dacrocystitis with cellulitis, with preseptal inflammation changes. Right side it looks fine, but in left side there is infection and inflammation changes. So this you might be seeing how this picture we got. This is volume rendering imaging. So after acquiring the normal CT scan, this is just a software so that we get this image just for presentation purpose, how the eyelid swelling is there in a one jinx we used to do. Otherwise, with this, we cannot diagnose anything. Okay, just for presentation we have given. So this is bone window. Okay, how the bones are very clear. See here, the culprit is found here. That is the ethmoid sinusitis with lamina papriciae dehiscence or a cortical breach is there, from where the source of infection is presented. Okay, so this is going into the extraconal aspect of the left orbit. The inflammation changes are seen here. Minimally, even into the orbit in the retrobulbar also, the fat is getting dirty. So there is also infection and inflammation. And preseptal also there is cellulitis changes. So that's where always when seeing the orbit, we should also see for the sinus also. Automatically that will get involved. If you have more interest, we can also see into the mastoids also, because sometimes this may present with cavernous sinus thrombosis and other venous thrombosis also. Very, very rarely it can present. So this is type 3, that is subperiosteal abscess. See here, this is the sagittal plane. We are seeing one peripheral enhancing fluid attenuating foci. This is a contrast study. This white line is the contrast. This black thing, what we are seeing, this arrow mark is the abscess. Abscess will not enhance in contrast study. Only the peripheral wall alone will get enhanced. So we differentiated between a fluid and as well as a solid thing. So this is not a tumor or something. You should not get deviated with it. Full of infections and inflammations noted. And because of the sinusitis in the right maxillary, okay, this is the right maxillary area. This is the nasal cavity, the ethmoid sinus, and the frontal. Complete obstruction is there of the osteometal unit, the frontoethmoidal recess, the sphenoethmoidal recess. Because of that, the infection and it is spread into the subperiosteal abscess. This is a type 3. So this is another case of a left ethmoid sinusitis. See here, left maxillary sinusitis with frontal, complete obstruction of a left frontoethmoidal recess, the osteometal units, the lamina papyracea breach is there. Because of that, the subperiosteal abscess is noted. Even the proptosis is seen here. But luckily, still it has not gone into the orbit. Orbital fat looks clear. So this is a case of abscess. So this is a complete infection and inflammation surrounding the eyeball, that is panophthalmitis with optic neuritis. So left optic nerve looks normal. This is the thickness of optic nerve, how thin it is. Okay, but in the right side, can you see the optic nerve? There is definitely thickening and a surrounding fat stranding. So this is a contrast study. So this is plain MRI. This is contrast study we do in the fat suppression sequences. So look at the type of enhancement. This white one is the contrast. Why do we get this enhancement abnormally? Because of inflammation. But in the left side, there is no that much of contrast enhancement. So this is a case of a panophthalmitis with the optic neuritis. This is coronal picture. That is from anterior to posterior we'll be seeing. This is left eyeball normal. The right eyeball, there is a circumferential enhancement of the contrast with surrounding fat inflammation and edematous signal changes. Okay. After the era of COVID or during the era of COVID, we'll be seeing a lot of cases of this, a fungal infection, that is a mucormycosis. So this was a case of a post-COVID patient who treated with abundant of steroid and they landed up with this mucormycosis. So you can ask, how do we diagnose mucormycosis with imaging? We can raise a possibility. The only clue for what we get is there's a T2 dark signs here. Because in normal sinusitis, we'll be seeing this, the collections in the maxillary sinus and the ethmoid in the frontal, that normal sinus. But what is the specialty of fungal sinus? Because of the fungal hyphae, in CT scan, you'll be seeing that hyperdensity. And in MRI scan, we'll be seeing this T2 hypointensity, that is T2 dark. These T2 dark foci are the fungal foci, so they will be causing the erosions and it has breached into the inferior orbital wall and into the orbit. And surrounding edematous changes in the bilateral maxillary area also is noted. This is the same case of mucormycosis. And see here, this is the sphenoid sinus, right? So sphenoid, usually sinusitis means it has to be whitened thing. But what is happening here? Internally, you found those T2 dark foci. These T2 dark foci are seen also surrounding the turbinates in the middle turbinate, inferior turbinate. Here also we see this black foci. So it's a case of mucormycosis. So orbital complications, these things we have seen: preseptal cellulitis, orbital cellulitis, cavernous sinus thrombosis, subperiosteal abscess. There are also intracranial complications in immunocompromised patients and patients who have not got the proper treatment. They may land up with these intracranial complications, even though they are quite rare in nowadays. So what are the intracranial complications? Are subdural empyema or epidural abscess. What is this Pott's puffy tumor? This is nothing else than the infection and that is happening in the frontal sinus. It will erode the frontal bone. Therefore, it lands up with osteomyelitis of the frontal bone. It presents like a mass-like thing, like a pseudotumor only. Okay, but it is just infection surrounding with inflammation. It will even spread to the brain also, landing up with the cerebral abscess, cerebritis, or meningitis. So this is one case where it's been presented with the superior ophthalmic vein thrombus. So superior ophthalmic vein will be like a hair-like structure. It's very, very difficult to visualize. In imaging, only in a fraction of few cuts we can pick up. But look at the diameter of the superior ophthalmic vein. It's grossly, it has been dilated because central non-enhancing foci is the thrombus. This black thing, what we are seeing is the thrombus. This white thing, what we are surrounding is the contrast enhancement. Obviously, superior ophthalmic vein thrombosis will lead to cavernous sinus thrombus. In axial sequence, see how the superior ophthalmic vein thrombus is presented. So sagittal sequence, we can nicely see the entire length of superior ophthalmic vein. So this is a case of cavernous sinus thrombosis. So these are all just one of the complications. So where if it is left untreated, what the patients will go and how imaging will show. That's why we are discussing this. Okay. So this is a case of cavernous sinus thrombosis. This is CT brain and orbit contrast. The normal internal carotid artery enhancement is noted, but the arrow marks what I have mentioned here is the cavernous sinus. There is no enhancement of contrast. So this shows that there is no enhancement in the cavernous sinus. It's a cavernous sinus thrombosis. And any cavernous sinus thrombosis can also be associated with the surrounding left temporal lobe, either infection or there also will be getting infarct. Okay. So meningitis, obviously, MRI is the better modality of choice, particularly MRI contrast will be the very good choice. But still in CT scans, normal, it will be normal in very early stages or even in advanced stages also CT can be normal. So MRI is the modality of choice if suspected with the meningitis. And if it is a TB meningitis, then we can see that ring enhancing lesions apart from the meningeal spread. So this is a case of complication causing meningitis. So see how these are abnormal, these flower-like patterns surrounding the sulci are noted in the MRI. So this is a flare sequence. This is the routine sequence what we do among. In the routine sequence itself, we have to pick up because in the sulci, these hyperintense white structures are noted. No, so these things we should not get in a normal flare sequence because sulci should be black in flare sequence. If this is there, then we will come to a conclusion, okay, that we are dealing with meningitis. We will suggest for contrast. Then in contrast, we get this picture of meningitis. If this orbital cellulitis is not treated, if it goes into the brain, these are all the complications we'll be seeing. So this is a case of tuberculous meningitis where we see these multiple ring enhancing lesions in the clival area. So TB or a tuberculoma will present with these ring enhancing lesions, these round lesions. Apart from that, very abnormal enhancement is noted in the cisterns area as well as in the sulci. So this is another complication of a cerebral abscess. So this round leg thing, suddenly if you see in MRI, you should not come to a conclusion that it is a tumor. Okay, so we should see all the sequences. So what is the sequence to say that it is dealing with cerebral abscesses? This sequence is the diffusion restriction. So diffusion restriction is the sequence in MRI to say whether are we dealing with a solid tumor or a liquid tumor. Because in diffusion restriction, we'll be getting this diffusion restriction, that is the abscess will be white in color. But the opposite of this diffusion is called ADC, and in ADC we'll be getting black in color. Can you ask, sir, in other tumors also, can we get diffusion restriction? Yes. Then how will we differentiate? For that, we do a contrast study. In contrast study, we see this peripheral enhancement. Abscess is central, there will be no enhancement. But a tumor will show a central, at least minimal enhancement or a poor enhancement or even a rich enhancement. But this peripheral thick wall enhancement we get in abscess with diffusion restriction, then we have to come to a conclusion that it's a case of cerebral abscess. Then what is this white thing, what we see like a map? That is vasogenic edema. That edema will be seen only in the white matter. So this is causing midline shift mass effect and the patient will have all neurological problem. What is this color image what I have presented? That is actually the perfusion imaging. So this shows about the blood supply to the mass lesion. So any blood supply is there, it will show in red color. So since there is no any supply, it is showing in blue color. So it is not a tumor, it is a abscess. So still the complication goes, if the infection goes much more deeper into the subdural compartment, it presents with subdural empyema. So this is the picture of empyema that has been spread into the tentorium and as well as the intrahemispheric fissure. Once again, abscess empyema will not show internal enhancement. Only in the periphery we see the enhancement of the walls. So last is this cerebral venous thrombosis. So if any complication, it goes into the brain and venous thrombosis is landed, this is how the picture will be. So this is a normal MR venogram. See, look at the beauty of this MRI. You need not give any contrast. You can do for even for the CKD patients. Even if the renal parameters are impaired, you can do that. No restriction because we are not doing any contrast. This is a non-contrast MR venogram. The entire venous system is seen. This is the normal superior sagittal sinus, inferior straight sinus, even the internal jugular veins also in the next cuts you will be seeing. But this is the case of CVT where there is no flow in the superior sagittal sinus. Abnormal, these veins are noted. No, these are all the cortical veins. Since the main venous system is completely interrupted, the paracortical veins and the cortical veins are getting dilated and it is draining through that. So this is the picture of a CVT. This is a normal picture of a MR venogram. It is a non-contrast. We can do for any patient with CKD or anything. Okay. The same picture only we'll be getting in CT venogram also. If we do CT venogram also, we'll get the same picture. This. So what is that Pott's puffy tumor? That is, if the frontal sinus, if the infection is not treated, if it goes into the frontal bone, it causes osteomyelitis, right? And this may be the source, because the source has to be identified. Because only treating this orbital cellulitis and this focally and this continuously, it will be keep on supplying the infection to the orbit because of the frontal sinus, or it may go into the bone, erode the bone. It presents like a soft tissue mass, but it is not a mass. It is infection with inflammation. This is called Pott's puffy tumor. If it goes deep into the brain, then definitely it causes brain abscess. If you give contrast study, you see this peripheral enhancement, because abscess central will not show any enhancement. Only in the periphery will be seeing enhancement. This is another case of a same Pott's puffy tumor within the extraaxial region with so much of abscess collection is noted. See here how the bilateral ethmoid sinusitis and frontal sinusitis is the source for this. So this is volume rendering images. From the routine images, we bring these color images and give a presentation this, how the erosions are seen in the frontal bone. And this is the soft tissue swelling. So what is the conclusion in this entire presentation is, CT is preferred for acute infection, sinus involvement, bony changes, and abscess detection. MRI is definitely superior for soft tissue detail, optic nerve involvement, intracranial extension. So we have to recognize these dangers, red flag complications like cerebral abscess, cavernous sinus thrombosis, vision threat can be life-saving. Thank you.